Hi guys, my name is Helena,
And my name is Annie.
and we're two of the SI leaders for Biosystems 2, and today we're going to go over some major concepts for respiratory system that are based on Dr. Keynes's lecture. So first we want to go over, just want to note that the function of the lungs is to maintain normal PaO2, which is the partial pressure of oxygen in arterial blood, PaCO2, and pH without stressing out the cardiac and pulmonary systems. The main four components in order to ensure adequate gas exchange includes having adequate ventilation, perfusion, distribution of ventilation, and diffusion of oxygen and carbon dioxide across the alveolar capillary membrane. So over here, we're going to go over a concept called PaO2, and we're actually going to go over what the symbol stands for. So the first letter P means partial pressure. The second letter indicates the location of the liquid or gas being exchanged. If it's a capital A, it's alveolar, and if it's a lowercase a, then it's referring to arterial. The last part is the gas that's being exchanged. So if it says O2, that's referring to oxygen, and if it's CO2, it's referring to carbon dioxide. Next, we're going to go over the structure of the lungs. As you can see here, there's a picture of the structure of the lungs. This is the conducting airway and the respiratory bronchioles, which is where gas exchange occurs. Be sure to note that there's no gas exchange during the conducting airway. Make sure you know that generation 0 to 16 are the conducting airways as shown here. Next, the bronchi are the large airways made up of cartilage and depends on smooth muscles, whereas the bronchioles are much smaller. While there's no gas exchange in the conducting airways, there is gas exchange starting from generation 17 in the respiratory bronchioles all the way to the alveolar ducts, which occurs from generation 21 to 23 as shown here. Also, the type of air that flows here is laminar flow, and this is where the respiratory bronchioles receive nutrients such as oxygen and carbon dioxide. The alveoli, which is found in generations 21 to 23 as stated here, is where most gas exchange occurs. Oxygen and carbon dioxide exchange through diffusion across the alveolar capillary membrane.
We want to go over a concept that is a bit confusing. We will discuss about VQ. By convention, VE is minute ventilation, and it is measured as the amount of exhaled air, and it equals tidal volume VT times respiratory rate. The amount going out is approximately proportional to perfusion, which is QP. The alveolar oxygenation concentration is an equilibrium determined by the ratio of ventilation to perfusion, VQ. So think of your V as ventilation and your Q as perfusion, and you need adequate V and Q for adequate gas exchange. In a normal person with normal gas exchange, the VE roughly equals to the QP, which is why VQ is equal to 1. When VQ is equal to 1, the PaO2 will approximate 100 torr, and PaCO2 will equal 40 torr. We will talk about the two abnormalities that can occur when VQ is not equal to 1. So when VQ is less than 1, you know the top part of the equation is smaller than normal, meaning that there's less ventilation occurring, which is why your PaO2 is decreased. You are still getting adequate perfusion of blood, which is Q, which is why your PaCO2 will increase. For VQ greater than 1, you have way more than adequate ventilation, but your perfusion, which is Q, is less. Here's an example. PaCO2 is equal to 40 divided by VQ. Remember, if you have VQ less than 1, your perfusion is greater than normal and ventilation is less than normal. So you will see an increase in PaCO2. Let's say that VQ is 0.5. Then based on the calculations, your PaCO2 will be 80, which is greater than the normal 40 torr. This means that you are not getting enough oxygen and the carbon dioxide is not leaving your body, which will lead to acidosis.
So now we're going to go over a topic including pH, acidosis, and alkalosis. pH needs to be heavily regulated, and it needs to be in a certain range from about 7.35 to 7.45 in our blood. Anything that's above that will lead to alkalosis, but if it's less than 7.35 to 7.45, it will lead to what is called acidosis. For acidosis, you know the pH will be less than normal because there's more acid in our blood, so the arrow's going down. Depending on whether if it's metabolic or respiratory acidosis, there's a difference in the other values. If it's respiratory, then it involves breathing, so think of carbon dioxide, you're breathing it in. So respiratory acidosis would involve CO2 not leaving your body. If you cannot remove carbon dioxide, which is basically the acid in our body, then you will have a decrease in pH. In this situation, the bicarbonate is unchanged, as shown by the arrow. For the metabolic acidosis, pH still goes down, so you still consider it acidosis because you have more acid in blood. But now you're dealing with the metabolic system, which involves bicarbonate and your kidneys. So you focus more on bicarbonate leaving or staying in your body for metabolic situations. Bicarbonate is a base in the body or in the blood, and if it's leaving more, then you're going to have less base in your system, which is why it leads to metabolic acidosis. The kidneys are responsible for doing this, and an easy way to remember this is metabolic deals with bicarbonate, respiratory deals with carbon dioxide. For alkalosis, you can have respiratory or metabolic. Alkalosis is increasing pH, so your system has more base. For respiratory, since it involves carbon dioxide, there's a decrease in CO2, so it's less acidic and more basic. For metabolic alkalosis, bicarbonate is increased, and since it's a base, then your blood is going to be more basic. A tip to help you remember this concept, because it's a little confusing, is just remembering which way the arrow goes. So the way we were taught was, remember M for metabolic, M equals matching, so the arrows for pH and bicarbonate go in the same direction. For example, for metabolic alkalosis and acidosis, you can see that the arrows for pH and bicarbonate are actually going in the same direction, and PCO2 is actually unchanged. If it's respiratory that you're dealing with, then you're retreating, so your pH and your PCO2 will always be opposite of each other.
So a confusing concept is right-to-left shunt. The most common cause of right-to-left shunt is lung disease, like pneumonia or pulmonary edema. This is when VQ is equal to 0. This is when your blood is able to flow from the right to the left heart without coming in contact with the exchange surface. It's a situation where there is no ventilation or gas exchange even though it's perfused. The old blood mixes with the blood from the left side, which is oxygenated, which is why it's called venous admixture. This results in severe hypoxia because a significant fraction of blood that was not ventilated from the right side, which means that the blood returns back to the heart underventilated. However, know that the PaCO2 might be low if there is sufficient healthy lung regions due to compensation for hypoxia. So if you look over here, here is the shunt, which is why you can see that the blood, the oxygen, has not increased. It stays the same, 75 over here and 75 over here, 40 over here, 40 over here, and the CO2 also remains the same. And then if you look on this side, there's no shunt, so there's still perfusion, and you see 75 has increased to 100, 40 has increased to 120, and 46 decreased because it's carbon dioxide, so carbon dioxide is leaving the blood. Therefore, when it mixes, this is old blood, and this is new blood, And then when it mixes, it's going to be the average of both. And this is the right to left shunt.
The next concept that we want to go over is actually airway obstruction and the graphs that are associated with it. So airway obstruction is the most common pulmonary function abnormality in children and adults. Over here, you're going to see graphs that basically are showing what would occur if you had obstructions in the different parts of the airway. So on the far left over here, right here, this is basically normal total lung capacity and residual volume for a person, so TLC and residual volume. And residual volume is the volume of air that's left in the lung after a complete exhalation. Airway obstruction causes airway closure, which basically traps air in the lungs during exhalation. This increases the lung volume at the end of the normal exhalation, and this is called hyperinflation. This is measured by an increased residual volume, RV. As for TLC, which is total lung capacity, it's the total volume of air in the lungs after maximal inhalation. It's the measure of lung size, basically. TLC can be decreased by decreased lung compliance, ventilatory muscle weakness, or extrinsic compression. A decrease in TLC is the definition of restrictive lung disease, right here. In the middle picture, TLC is decreased. So as you can see here, there's a shift of the graph to the right. The individual is not able to store as much air after maximal inhalation. So you see a shift in the graph to the right, and the residual volume actually remains the same. With the large airway obstruction shown here in this graph, the top part of the graph actually corresponds to large airways. This is middle, and this is small. So if this area is actually decreased and the graph has been cut off from the top region, that means that we have a large airway obstruction. And basically, when determining these graphs, based on where the graph has been cut off or changed, then that's going to determine what kind of obstruction it is and what area of the lungs it is or the airways it's occurring. For the middle airway and small airway obstruction, you can actually see that both the middle and the small airway region is decreased. The graph has decreased, whereas compared to, let's say, normal, it would be like a triangle here, but it's not. You have a dent here. And then for small airway obstruction, the large and the medium airway is normal. And then over here, the small airway is actually obstructed, so you see a decline here, as shown by this arrow over here. And then severe airway obstruction is when every region, the large, medium, and small airways are all obstructed. That's why you see the arrows, they're all like decreasing over here. And then now this last graph over here is showing what would happen if an asthmatic individual were to take a bronchodilator. So this graph is an individual who has asthma, and then this blue graph is showing what would happen after the individual were to use their bronchodilator.
So the last thing we'll go over is the respiratory system balance. Ventilatory muscle power and central respiratory drive must be adequate to overcome the respiratory load. Respiratory failures result when ventilatory muscle power and/or central respiratory drive are inadequate to overcome the load. This can occur due to a decrease in the muscle power, a decrease in the central respiratory drive, an increase in the respiratory load, or any combination of the above. Even though your lungs have a good amount of gases delivered to you, the muscles need to have enough muscle power to overcome the load. Thus, we need to consider the muscle power, the controlled breathing, which is done through the central drive, and the load. So in a normal person, you have adequate ventilation, meaning your ventilator muscle power and central drive can overpower the respiratory load. Here's a normal person, and this is adequate enough. So in the second part, you have a decrease in the muscle power and a decrease in the central drive. And then if you have such a decrease, then you can have an increase in the load because this is not enough to overpower that and to compensate it. So you have respiratory failure. In the third one, what your body normally does is that it will have a normal compensation for your severe lung disease. And in this case, even though the respiratory load is so high, you have enough compensation for your muscle power and your central drive. And because it is, you have adequate ventilation, and thus you don't really have respiratory failure.
Okay, guys, so that's actually the end of this short video that we made. It's not everything. It doesn't cover all the material that's involved in Dr. Keynes' lecture, but definitely would go over his learning objectives. And of course, if you guys have any questions, you can go ahead and contact any of the BioSys SI leaders, and we'll be happy to help you. Thank you.
Thank you.